Welcome to the Deep Dive, where we take a stack of information, distill it down, and really pull out those most important nuggets of knowledge.
That's the plan.
Today, we're doing a comprehensive deep dive into kidney disease and renal function. And this one is specifically for you, our third-year medical students, as you're navigating your renal block, getting ready for exams.
Yep. Consider this your maybe shortcut to getting a solid grasp on it, packed with the essential facts and those crucial clinical links you'll need.
Exactly. We've gathered insights from expert lectures covering, well, pretty much everything from basic renal physiology, lab diagnostics, all the way to diabetic and hypertensive nephropathy, nephrotoxins.
And even assessing renal function in kids, which has its own unique challenges.
Right. Our mission. Make sure you walk away feeling informed and honestly ready to tackle those tricky questions, especially the board-style ones. Okay, let's unpack this.
Let's do it.
So let's kick things off with a bit of a refresher. The kidney's core functions, we often just think filter, right? But it's so much more complex, isn't it? Beyond just making urine, what are those really vital, maybe less obvious roles it plays?
Oh, absolutely. It's way more than just a filter. It's fundamental for homeostasis. We're talking precise balancing of electrolytes, sodium, potassium, water regulation, and critically acid-base balance, managing hydrogen ions, bicarbonate.
Constantly adjusting.
Constantly. It excretes the excess, producing urine which carries away nitrogenous waste and various toxins.
And something that often surprises students, definitely a high-yield concept for you, is that the kidney is also a metabolic organ. We always think liver for gluconeogenesis, but the kidney, it chips in significantly, especially if you're fasting for a while.
That's a great point. And don't forget hormone synthesis. Active vitamin D calcitriol, which is crucial for calcium absorption, erythropoietin for red blood cells, renin kicking off the whole RAAS system for blood pressure control.
And that metabolic function extends to drugs too, right? Drug metabolism, excretion. Hugely important when you're managing meds in patients with kidney problems. A connection you will absolutely see on the wards.
Definitely. And all these functions, they boil down to the nephron. That's the functional unit. It's this tiny, intricate structure. Glomerulus, proximal tubule, loop of Henle, distal tubule, collecting duct.
And its main job is regulating water and solutes, filtering the blood, taking back what the body needs, getting rid of the rest as urine.
Precisely.
Okay, so let's dive into that first part. Glomerular filtration. Can you walk us through that structure? The arteriole's Bowman's capsule.
Sure. So blood flows in through the afferent arteriole, think A for arrive, which is wider. It goes into this capillary tuft, the glomerulus, nestled inside Bowman's capsule. Then it flows out through the efferent arteriole E for exit, which is narrower.
And that difference in width creates pressure, right?
Exactly. That pressure difference helps force plasma fluid out of the capillaries and into Bowman's capsule. That fluid is called the ultrafiltrate.
But not everything gets through. There's that barrier.
The glomerular filtration barrier, yes. It's like a sophisticated sieve with 3 layers. First, the endothelium of the capillaries, which has little windows, fenestrations. Then the glomerular basement membrane, the GBM. And finally, the podocytes, specialized cells with foot-like processes wrapped around the capillaries.
So what gets through is based on size and charge.
Absolutely. Small molecules pass easily. Large ones like proteins generally don't. And charge plays a role too. The barrier has a negative charge, which repels negatively charged molecules like albumin.
And the main force pushing fluid out is that glomerular hydrostatic pressure.
That's the main driving force, yes. But it's opposed by forces pulling fluid back in the colloid osmotic pressure from proteins still in the blood and the hydrostatic pressure within Bowman's capsule itself.
And the kidney cleverly regulates this whole thing.
Oh, yeah. Nerves, the renin-angiotensin system we mentioned, even NP-atrial natriuretic peptide, they all fine-tune glomerular filtration.
Okay, ultrafiltrate formed. Now the tubules get to work. What happens first in the PCT?
Right, the proximal convoluted tubule, or PCT, this is the real workhorse. It's the most metabolically active part, reabsorbing like 60 to 80% of the filtrate.
Wow, that much. What's it taking back?
Almost all the glucose and amino acids, most of the bicarbonate, sodium, chloride, potassium, water. It's driven mainly by active transport of sodium out of the tubule cells. Water just follows passively by osmosis, so the filtrate volume drops massively here.
Okay, then it heads into the loop of Henle. This part always seemed like the kidney's clever trick for concentrating urine.
It really is brilliant. The descending limb plunges down into the salty medulla. It's very permeable to water, but not really to salts. So water leaves and the filtrate gets really concentrated, very hypertonic.
And then the ascending limb.
It flips the script, As the filtrate goes back up, the ascending limb is basically impermeable to water, but it actively pumps out sodium and chloride into the surrounding tissue, the interstitium.
Making the medulla salty.
Exactly. That creates the osmotic gradient. It's essential for the kidney's ability to concentrate urine later on. This countercurrent mechanism, classic exam material. Definitely know it.
Got it. So after the loop, we hit the distal convoluted tubule, the DCT. More fine-tuning.
Yep. More sodium reabsorption, influenced by aldosterone here. Chloride follows. Calcium reabsorption happens here too, under the influence of parathyroid hormone and vitamin D, and potassium secretion can occur.
And finally, the collecting duct.
Right. This is where the final adjustments happen, especially to water balance, controlled by ADH or vasopressin. It also has principal cells dealing with sodium and potassium and intercalated cells that are key for acid-base balance, secreting acid or bicarbonate as needed. It determines the final urine volume and concentration.
Understanding that whole journey is just fundamental, isn't it?
Yeah.
To grasp what goes wrong in kidney disease.
Absolutely. You can't understand the pathology without the physiology.
Okay, so that's the healthy kidney. But things can go wrong, often silently at first. Let's shift to chronic kidney disease, CKD. It's often picked up late. What are those really key risk factors we need to be looking for in our patients?
Yeah, that's crucial for clinical practice. Hypertension is a huge one. Super common and often not well controlled. Diabetes, of course, is another major driver.
Right.
Then you've got glomerulonephritis, maybe from autoimmune diseases or infections. Recurrent UTIs can cause damage over time in some parts of the world, like parts of Africa. Even bilharzia is a factor. And don't underestimate NSAIDs. Overuse is a surprisingly common issue.
So how do we actually define CKD for, say, our notes or for diagnosis?
Good question. It's defined by the presence of kidney damage, either structural or functional abnormalities lasting for 3 months or more.
Okay, structural damage. What does that look like?
That could be things you see on ultrasound, like small kidneys, or findings on a biopsy. Clinically, it often means protein, especially albumin, in the urine, or abnormal things in the urine sediment, like casts or red blood cells.
And functional damage. That's the GFR measure.
Exactly. Specifically, a glomerular filtration rate, or GFR. That's less than 60 milliliters per minute per 1.73 square meters. Again, for more than 3 months. Just for context, normal GFR is usually around 120. And yeah, it's always adjusted for body surface area.
And there are stages, right, based on that GFR.
Yes, the CI-EGO classification, 5 stages. Stage 1 means kidney damage, but normal or even high GFR, maybe over 90. Then it drops through stages 2, 3, 4, down to stage 5, which is kidney failure, typically a GFR below 15.
And stage 3 is split, isn't it? 3A and 3B?
It is. Stage 3A is GFR 45 to 59, and stage 3B is 30 to 44. That distinction is important because the risk of complications and progression really starts to increase significantly once you hit stage 3B. It helps guide management.
Okay. And you mentioned protein in the urine, proteinuria, as a sign of damage. How important is that as a marker?
Oh, incredibly important. It's not just a sign of damage. It's a major factor in prognosis and progression. We classify it broadly. Nephrotic range protein is high, over 3.5 grams in 24 hours. Non-nephrotic is less than that.
Does the type of protein matter?
It can. Glomerular proteinuria usually means albumin is leaking through a damaged glomerular barrier. Tubular proteinuria involves smaller proteins not being reabsorbed properly by the tubules. Clinically, we focus a lot on albuminuria, especially in diabetes.
So why is tracking proteinuria so critical?
Well, first, it's key for diagnosing and monitoring diabetic kidney disease. Second, it helps confirm CKD diagnosis. Third, and this is huge, the amount of protein in the urine is a powerful predictor of how fast CKD will progress and, crucially, the risk of cardiovascular events. More protein generally means a worse prognosis.
How do we measure it practically? Dipsticks.
Dipsticks are useful for screening, yeah. They're semi-quantitative, usually picking up protein over about 300 milligrams per day, mostly albumin.
Right.
But for accurate quantification, you need a lab test.
Like a 24-hour urine collection. That sounds cumbersome.
It is, especially for outpatients. So more commonly now, we use spot urine samples to measure the albumin to creatinine ratio, ACR, or the protein to creatinine ratio, PCR. These ratios correlate pretty well with 24-hour excretion and are much more convenient.
Good tip. But can protein show up temporarily? Like if someone has a fever?
Absolutely. Transient proteinuria can happen with UTIs, fever, heavy exercise, even just standing up for a long time. In some young people, that's orthostatic proteinuria. So if you find it on a dipstick, you always need to repeat the test and ideally quantify it to confirm it's persistent.
Okay, moving to GFR assessment. Serum creatinine is the go-to test, right? What are its properties?
Yeah, it's the most common biomarker. Creatinine comes from creatine phosphate breakdown in muscle. It's freely filtered by the glomerulus. There's also a small amount secreted by the proximal tubules, and that secretion actually increases a bit as GFR falls, which complicates things slightly.
It was affected by muscle mass.
Definitely. Muscle mass is key. So things like age, gender, ethnicity can influence baseline creatinine levels. Diet, particularly high protein intake, and some medications can also affect it.
But here's the catch, right? Creatinine might look normal even when kidney function has declined quite a bit.
That's the crucial pitfall. Serum creatinine often doesn't rise above the normal range until GFR has already fallen by, say, 50% or more, maybe from 120 down to 60.
Why is that?
Because the remaining healthy nephrons compensate, they hyperfiltrate, working harder to pick up the slack. So relying solely on serum creatinine, especially just looking if it's in the normal range, can give you a false sense of security. You can miss significant early CKD.
So if creatinine isn't perfect, how do we get a better handle on GFR? What's the gold standard versus what we actually use?
Well, the true gold standard for measuring GFR is inulin clearance. But it's complex, invasive, really only used in research. Measured GFR using other substances like iohexol or radioactive tracers like chromium EDTA is sometimes done in specific situations like for precise drug dosing in oncology, especially pediatrics, but it's still time-consuming.
So for everyday practice,
For everyday practice, we rely on estimating GFR, the eGFR. We use equations that plug the serum creatinine level into formulas along with age, gender, and sometimes race, although the race variable is becoming controversial and being removed from newer equations.
which equations are preferred? MDRD, CKD, EPI.
The two main ones you'll see are the MDRD, modification of diet in renal disease equation, and the CKD EPI, chronic kidney disease epidemiology collaboration equation. Generally, CKD EPI is preferred now, especially for adults. It's considered more accurate across a wider range of GFRs, particularly at higher levels above 60, where MDRD tends to underestimate.
But these equations aren't perfect either, are they? When should we be cautious about using eGFR?
No, they definitely have limitations. You need to be cautious using standard eGFR equations in situations like pregnancy, significant edema or ascites, extremes of muscle mass or nutritional status, think bodybuilders or people with cachexia or amputations. Also in the very young or very old, during acute kidney injury, or in patients on dialysis, they're designed for stable CKD.
Are there other markers we can use maybe to overcome some of creatinine's limitations?
Yes, statin C is gaining traction. It's a small protein produced by all nucleated cells at a pretty constant rate. Like creatinine, it's freely filtered by the glomerulus, but unlike creatinine, it's not secreted or reabsorbed significantly by the tubules.
And the advantage is?
Its levels aren't really affected by muscle mass or diet, so it can be a more reliable marker in people where creatinine might be misleading, like the elderly or those with low muscle mass. It's particularly useful, some say, in that GFR range between 60 and 90, the sort of gray zone. Some equations now combine creatinine and cystatin C for even better estimates.
What about urea? We always measure U and E together.
Urea, or BUN, blood urea nitrogen, in the U.S. is less reliable specifically as a marker of GFR compared to creatinine or cystatin C. It's influenced by too many other things: protein intake, hydration status, liver function, tissue breakdown, GI bleeding, steroid therapy. It can go up for reasons other than just reduced filtration. So we look at it, but more in the context of the overall clinical picture, maybe hydration or uremic symptoms.
Right. Okay. So CKD progresses.
Yeah.
What are the major complications we need to anticipate and monitor for? We know mortality is higher.
Much higher, sadly. The big complications you'll manage are cardiovascular disease, that's the #1 killer in CKD patients, then anemia, mineral and bone disorder, often called CKD-MBD, and things like cognitive impairment and increased risk of infections.
Let's break those down. Cardiovascular disease. What does the typical lipid profile look like in CKD? It's not always straightforward, is it?
No, it's often a bit different from standard hypercholesterolemia. You typically see high triglycerides, low HDL, the good cholesterol, and a shift towards small, dense, more atherogenic LDL particles. Interestingly, total cholesterol, or even LDL cholesterol levels, might actually be normal or even low, especially in advanced stages, but the pattern is pro-atherogenic.
Okay. And anemia. Why does that happen?
It's multifactorial. The main reason is the kidneys aren't producing enough erythropoietin, EPO, the hormone that stimulates red blood cell production in the bone marrow. But you also have other contributing factors. Iron deficiency is common, partly due to poor absorption or blood loss. Folate and B12 deficiency can occur from poor diet. There are platelet function issues leading to potential bleeding. and just the general effect of chronic inflammation, the anemia of chronic disorder.
So lab workup for anemia would include.
A full blood count, obviously, to check hemoglobin and red cell indices. Then iron studies, ferritin, transfer, and saturation are crucial, and checking B12 and folate levels is important too.
But what about electrolytes? We worry about potassium, right?
Absolutely. Hyperkalemia becomes a major concern as GFR drops, usually significantly below 30 millimin. The kidneys are the main route for potassium excretion, so when they fail, levels rise. And many drugs we use in CKD, like ACE inhibitors, ARBs, potassium-sparing diuretics, even NSAIDs, can worsen it. So close monitoring of serum potassium is vital.
And acid base.
Patients typically develop a metabolic acidosis, specifically a high anion gap metabolic acidosis. This happens because the kidneys can't excrete the daily load of acid produced by metabolism, and they also retain unmeasured anions like phosphate, sulfate, and organic anions.
Okay, now CKD, MBD, mineral and bone disorder. This sounds complicated. Can you simplify the pathophysiology?
I'll try. It's a domino effect. Step 1. GFR falls so the kidneys can't excrete phosphate properly. Serum phosphate starts to rise. Step 2, high phosphate binds with calcium in the blood, causing serum calcium levels to drop. Step 3, low calcium, and also the high phosphate itself, stimulates the parathyroid glands to pump out more parathyroid hormone, PTH.
Secondary hyperparathyroidism.
Exactly. Step 4. There's another hit because the diseased kidney is also less able to activate vitamin D to calcitriol, the 125 form. Active vitamin D is needed for calcium absorption from the gut. So less active D means less calcium absorption, further lowering serum calcium and further stimulating PTH.
Wow, a vicious cycle.
It is. And high PTH tries to fix things by pulling calcium and phosphate out of bone, leading to bone disease, and also tells the kidney to excrete more phosphate and make more active vitamin D, but the failing kidney just can't respond properly.
So the labs we check are calcium, phosphate, and PTH.
Those are the key ones. You'll typically see low or normal calcium, high phosphate, and high PTH in secondary hyperparathyroidism due to CKD. Alkaline phosphatase might also be high, reflecting increased bone turnover.
And when things get really bad, when urea is sky high, we talk about uremia. What are the clinical signs we might see?
Yeah, the signs of uremia. Patients might look pale from anemia, have easy bruising from platelet dysfunction. They might have this characteristic uremic frost on the skin or uremic fetor, a sort of ammonia-like smell on the breath. Hypertension is common. You might hear a pericardial friction rub if they develop uremic pericarditis, neuropathy, tingling, numbness, nausea, vomiting, loss of appetite, fatigue, itching. It's a systemic illness.
And for monitoring progression risk.
Yeah.
Especially in diabetics.
For diabetics, keeping a close eye on blood glucose control with HbA1c is paramount. Managing blood pressure aggressively is key for everyone, and checking that lipogram periodically to manage the dyslipidemia.
Okay, let's shift focus now specifically to glomerular diseases. You said this is the most common cause of end-stage kidney disease worldwide.
That's right. Understanding these is critical, and how they present often relates directly back to which part of that glomerular filtration barrier, the endothelium, the GBM, or the podocytes is primarily affected.
And we can think of them as primary versus secondary.
Yeah, exactly. Primary means the kidney is the main or only organ involved, often idiopathic, meaning we don't know the exact cause. Secondary means the glomerular injury is part of a wider systemic disease, like lupus nephritis and SLE, or diabetic nephropathy.
So let's revisit that filtration barrier briefly. Endothelial cells, GBM, podocytes. Injury location dictates the syndrome.
Precisely. And this leads us nicely into the two major clinical syndromes you need to know, nephrotic syndrome and nephritic syndrome. Understanding the difference is absolutely key.
Let's start with nephrotic syndrome. What's the primary damage site?
Nephrotic syndrome is fundamentally a podocytopathy. The damage is primarily to the epithelial layer, those podocytes. When they're injured, their foot processes become effaced, flattened, and spread out. This messes up the filtration slits between them, making the barrier leaky to large proteins, especially albumin. Importantly, this is generally considered a non-inflammatory process at the glomerular level.
So the clinical picture follows from that massive protein leak.
Exactly. The defining feature is heavy proteinuria, usually over 3.5 grams per day, which leads to hypoalbuminemia, low albumin in the blood, typically less than 30 GL. This drop in plasma oncotic pressure causes fluid to shift out of the blood vessels into the tissues, leading to generalized edema. It's often quite dramatic, especially periorbital edema around the eyes, particularly in the morning.
What else do we see?
You also get hyperlipidemia. The liver tries to compensate for the low albumin and low oncotic pressure by ramping up production of lipoproteins, leading to high cholesterol and triglycerides. Urine output is usually normal, blood pressure can be normal or sometimes elevated, and renal function might be okay initially or become impaired.
And the urine itself, what does the sediment look like?
The urine sediment is typically described as bland, meaning you don't see many cells or casts. It's mostly just the protein, which can make the urine look frothy or foamy.
Are there major complications associated with losing all that protein?
Yes, definitely. Two big ones. Increased risk of infection, because you're losing immunoglobulins and complement proteins in the urine, and an increased tendency to clot, thromboembolism, partly because you lose natural anticoagulants like antithrombin III, and also because of changes in other clotting factors.
You mentioned theories about the edema underfill versus overfill.
Right. The classic underfill theory says low albumin reduces plasma oncotic pressure, fluid leaks out, intravascular volume drops, which then activates RAAS, ADH, sympathetic nervous system to retain salt and water, worsening the edema. The overfill theory suggests there might also be a primary defect in the kidney's ability to excrete sodium, leading to volume expansion from the start. Probably a bit of both is involved, depending on the cause.
Okay, so that's nephrotic. Now, nephritic syndrome. What's the key difference in pathology?
Nephritic syndrome is classic glomerulonephritis. Here, the primary injury is typically inflammatory, often involving the endothelial cells or the GBM itself. Immune complexes might deposit, complement gets activated, inflammatory cells rush in. It's an active inflammation within the glomerulus.
And the clinical picture reflects that inflammation.
Absolutely. Because the glomeruli are inflamed and damaged, filtration drops. So you see reduced urine output, oliguria. The inflammation and damage also lead to impaired sodium and water excretion, causing volume expansion and hypertension. Hypertension is almost always present. And renal dysfunction, a rise in creatinine, drop in GFR, is also characteristic.
And the urine. Not bland this time.
Definitely not bland. The key finding is hematuria blood in the urine. Because the inflamed glomerular barrier is damaged, red blood cells leak through. And crucially, when you look at the urine sediment under a microscope, you see an active sediment.
What's in an active sediment?
You'll see red blood cells, and often they look dysmorphic, distorted shapes, sometimes described as looking like Mickey Mouse ears because they've been squeezed through the damaged GBM. You'll also typically see red blood cell casts, which are basically clumps of red cells molded into the shape of the renal tubules, indicating the bleeding is coming from the glomerulus or tubule. You might see white blood cells and some proteinuria too, but usually the proteinuria is less severe than in nephrotic syndrome, subnephrotic range. Edema can be present due to salt and water retention, but may be less massive than in nephrotic syndrome. And typically, there's no significant dyslipidemia.
Wow, okay. So nephrotic, podocyte injury, heavy protein, bland urine, nephritic, inflammation, hematuria, active sediment, HTN, renal dysfunction. That distinction is huge.
Foundational. You absolutely need to know the difference for your exams.
What are the major primary causes of nephrotic syndrome?
The big ones. In children, the most common cause by far is minimal change disease, MCD. On light microscopy, the glomeruli look normal, hence minimal change. Immunofluorescence is negative, but on electron microscopy, you see widespread effacement of those podocyte foot processes. The good news is it's often highly responsive to steroids, especially in kids. In adults, it's different. Focal segmental glomerulosclerosis, FSGS, becomes more common. Focal meaning only some glomeruli are affected. Segmental meaning only part of each affected glomerulus shows sclerosis or scarring. It's particularly common in individuals of African descent, partly due to genetic variants like APL1, and there's a strong association with HIV infection. Unfortunately, FSGS often responds poorly to steroids and frequently progresses to CKD.
What else is common in adults?
Membranous glomerulonephritis, MGN, is another major cause in adults. This is an immune complex disease where antibodies, often against the phospholipase A2 receptor, PLA2R, on podocytes, form deposits on the outer side of the GBM, subepithelium. On biopsy, you see thickening of the GBM and characteristic spikes projecting outwards. It can be primary, idiopathic anti-PLA2R, or secondary to things like infections, hepatitis B, autoimmune diseases, lupus, or even malignancy. Prognosis is often described as a rule of thirds. About a third remit spontaneously, a third have persistent proteinuria, and a third progress to end-stage renal disease. And we should mention membranoproliferative glomerulonephritis, MPGM. This one's a bit complex because it can actually present as either nephrotic or nephritic syndrome, or a mix. Pathologically, it involves thickening of the GBM and increased cellularity within the glomerulus, often showing tram track or double contours on silver stain due to splitting of the GBM. It often progresses to chronic renal failure.
And important secondary causes.
Key secondary causes to remember include diabetic nephropathy, lupus nephritis, which can cause various patterns, often a full house on immunofluorescence with IgG, IgA, IgM, C3, C1q, amyloidosis, diagnosed with Congo red stain showing apple green birefringence under polarized light, and HIV-associated nephropathy, HIVAN, which is often a collapsing form of FSGS.
Okay, managing these. How do we approach it?
It depends. If you can identify an underlying cause, like treating an infection, managing lupus, controlling diabetes, that's the primary goal. For primary glomerular diseases, management often involves two arms: general measures and specific immunosuppression.
What are the general measures, especially for nephrotic syndrome?
For nephrotic syndrome, you manage the symptoms. Fluid and salt restriction plus diuretics for the edema. Often need high doses of loop diuretics like furosemide because they get bound to the albumin lost in the urine. Sometimes you need to add a thiazide diuretic for synergy. In severe refractory edema, sometimes IV albumin infusions followed by diuretics or even ultrafiltration might be considered.
What about the proteinuria itself?
Definitely want to reduce it. ACE inhibitors, or ARBs, are key here. They lower pressure within the glomerulus, but they also seem to have direct protective effects on podocytes. They also help control blood pressure, which is vital.
And the hyperlipidemia.
Statins are usually used to manage the hyperlipidemia. They might also have some additional antiproteinuric effects.
And the clotting risk.
You need to assess the risk. In patients with very severe hypoalbuminemia, for example, 20 or 25 GL, and heavy proteinuria, anticoagulation might be considered to prevent clots, but it's a case-by-case decision balancing risk and benefit.
And then there's immunosuppression.
Yes, for many primary glomerular diseases, especially those thought to be immune-mediated, steroids like prednisone are often first line, particularly for minimal change disease, and often tried in FSGS. If steroids don't work or aren't suitable, other agents are used depending on the specific disease and biopsy findings, things like calcineurin inhibitors, cyclosporine, tacrolimus, cyclophosphamide, mycophenol mofetil, or tuximab.
And always general care, right?
Always avoid nephrotoxic drugs, monitor blood pressure closely, track renal function and electrolytes. It's complex, long-term management.
Okay, let's drill down into two huge players in CKD, diabetes and hypertension. First, diabetic nephropathy. You said it's the #1 cause of ESRD.
It is, worldwide, a massive public health problem. The earliest sign you can pick up, often years before GFR declines, is microalbuminuria, just small amounts of albumin leaking into the urine.
And there's that link with the eyes.
Yes, the renal retinal syndrome. The severity of diabetic kidney disease often correlates quite well with the severity of diabetic retinopathy. So if you see advanced eye changes, you should definitely be looking closely at the kidneys, and vice versa.
What's actually happening in the glomerulus pathologically?
Several things. There's increased permeability of the GBM, partly due to changes in its composition, like deposition of type ID collagen and effects of glycosylation, glucose sticking to proteins. There's also often early hyperfiltration. The GFR might actually be increased initially.
And the classic microscopic findings.
Microscopically, you see diffuse thickening of the GBM and expansion of the mesangium, the central part of the glomerulus. But the most characteristic lesion, though not always present, is nodular diabetic glomerulosclerosis, featuring Kimmel-Steele-Wilson nodules. These are rounded, laminated, pink-staining nodules of matrix material in the mesangium.
Is there anything else that's really specific for diabetes?
Yes. Something considered pathognomonic, meaning it really points strongly to diabetes, is hyaline arteriolosclerosis thickening and hyalinization of the vessel walls, affecting both the afferent and the efferent arterioles. Usually in hypertension alone, it primarily affects the efferent. Seeing it in both strongly suggests diabetes. You also see tubular changes and increased susceptibility to infections like pyelonephritis and even renal papillary necrosis.
Okay, now hypertensive nephropathy. Hypertension can cause kidney disease, but kidney disease can also cause hypertension, right?
Exactly. It's often a vicious cycle. Let's talk about hypertension causing kidney damage. The milder, more common form is benign nephrosclerosis. This develops over years of mild to moderate, often poorly controlled hypertension.
What do the kidneys look like?
Grossly, the kidneys tend to be small, shrunken, with a granular surface. Microscopically, the small arteries and arterioles show that hyaline arteriolosclerosis we mentioned, causing thickening of the walls and narrowing of the lumen. This reduces blood flow, leading to ischemic damage in the glomeruli, wrinkling of the GBM, eventual sclerosis, and tubules, atrophy, interstitial fibrosis.
And the more severe form.
That's malignant hypertensive nephropathy associated with accelerated or malignant hypertension, really high blood pressure, like diastolic 130 milliliters G, often with papilledema, swelling of the optic disc, and rapidly declining renal function. This is a medical emergency.
What are the key microscopic features there?
Two key features. Fibrinoid necrosis of the arterioles looks like bright pink, smudgy material on the vessel wall, indicating severe damage, and hyperplastic arteriolosclerosis, where smooth muscle cells proliferate in the intima, causing marked thickening in a characteristic concentric laminated pattern often described as an onion skin lesion. You might also see little pinpoint hemorrhages on the kidney surface, giving it a flea-bitten appearance.
Got it. Briefly, what about diseases primarily affecting the tubules and interstitium?
Good point. Acute tubular necrosis, ATN, is the most common cause of acute kidney injury, AKI, especially in hospitalized patients. It's usually caused by either ischemia, lack of blood flow, or toxins, like certain antibiotics or contrast dye. Microscopically, you see damage and death of the tubular epithelial cells, often with sloughing into the lumen-forming casts. Then there's tubulointerstitial nephritis, TIN. This is typically an inflammatory reaction in the interstitium and tubules, often an allergic or hypersensitivity reaction to drugs, NSAIDs, antibiotics like penicillins or sulfonamides, proton pump inhibitors are common culprits. You see an inflammatory infiltrate, often rich in eosinophils. Importantly, it's often reversible if you stop the offending drug quickly.
And kidney infections.
Pyelonephritis. That's infection involving the kidney parenchyma, tubules and interstitium, and the renal pelvis. Acute pyelonephritis is usually bacterial, often ascending from a bladder infection. Chronic pyelonephritis involves scarring and is often related to recurrent infections, reflux, or obstruction. Finding white blood cell casts in the urine is highly suggestive of pyelonephritis.
One more category, vasculitis. How does that affect the kidney?
Vasculitis, inflammation of blood vessels, can affect kidneys significantly. While any size vessel can be involved, it's the small vessel vasculitides that most commonly present with kidney problems, typically as a rapidly progressive glomerulonephritis.
Which ones should we know?
The main ANCA-associated vasculitides. Granulomatosis with polyangiitis, GPA, formerly Wegener's, often involves the respiratory tract and kidneys with necrotizing granulomas and glomerulonephritis. Microscopic polyangiitis, MPA, causes necrotizing vasculitis without granulomas, frequently affecting kidneys and lungs. And eosinophilic granulomatosis with polyangiitis, EGPA, or Churg-Strauss, associated with asthma, eosinophilia, and vasculitis, affecting various organs, including the kidney. They often cause a severe crescentic glomerulonephritis.
Okay, let's talk more about nephrotoxins and how they cause acute kidney injury, AKI. You said this is really common, especially drug-induced.
Extremely common. In hospitalized patients, particularly critically ill ones, drugs might be responsible for maybe up to half or even more cases of AKI. So recognizing potential nephrotoxins is vital.
It feels like a huge list of drugs. Is there a better way to think about it than just memorizing names? Maybe by mechanism?
Absolutely. Thinking about the mechanism of injury is much more helpful for understanding and predicting problems. We can group them.
Okay, what's one major mechanism?
One is causing vasoconstriction or altering hemodynamics within the glomerulus. Drugs that reduce blood flow into the glomerulus or increase flow out can drop the pressure needed for filtration. Classic examples are NSAIDs. They block prostaglandin synthesis, and prostaglandins normally help keep the afferent arteriole dilated. So NSAIDs can cause afferent vasoconstriction, reducing blood flow in. On the other end, ACE inhibitors and ARBs cause vasodilation of the efferent arteriole. While this is usually protective in CKD by lowering intraglomerular pressure, if a patient relies on efferent constriction to maintain filtration, like someone with bilateral renal artery stenosis, giving these drugs can acutely drop GFR and cause AKI.
So patient context matters a lot here.
Hugely. Patients who are dehydrated, have heart failure, sepsis, or underlying kidney disease are much more vulnerable to these hemodynamic effects.
What's another mechanism? Direct damage to the tubules.
Yes, direct tubular toxicity, especially to the proximal tubule cells, which are very metabolically active and handle a lot of solutes and toxins. High renal blood flow concentrates the toxins there.
Which drugs do this?
Aminoglycoside antibiotics, like gentamicin, ampicin, are notorious. They get taken up by proximal tubule cells and cause damage. Amphotericin B, an antifungal, is another classic example. Radiocontrast agents used for imaging can also be directly toxic. Some chemotherapy drugs, too. These often cause ATN.
Okay, what about that allergic reaction type, TIN?
Right, acute interstitial nephritis, AIN. This is a hypersensitivity reaction in the kidney's interstitium. It's not usually dose-dependent and can happen days or even weeks after starting a drug.
Common culprits?
Again, NSAIDs can cause AIN, as well as hemodynamic AKI or even nephrotic syndrome sometimes. Many antibiotics, penicillins, cephalosporins, sulfonamides, fluoroquinolones, proton pump inhibitors, PPIs, are increasingly recognized. Diuretics like thiazides and loop diuretics, anti-seizure meds. You often see fever, rash, eosinophilia along with the AKI, but not always. The key is stopping the drug. It's often reversible then.
Can drugs cause physical blockage, like crystals?
Yes, crystal nephropathy. Some drugs, or their metabolites, are poorly soluble in urine and can precipitate out, forming crystals that can block tubules and cause APN or an inflammatory reaction. Solubility often depends on urine pH and concentration.
Examples?
Acyclovir, especially high-dose IV, sulfonamides, methotrexate, even high doses of vitamin C can lead to oxalate crystals. Maintaining good hydration and sometimes altering urine pH can help prevent this with certain drugs.
Are there other mechanisms? Damage to the glomerulus itself?
Less common from drugs, but yes. Some drugs can cause glomerular injury, sometimes mimicking minimal change disease or FSGS, leading to nephrotic syndrome. NSAIDs again, and lithium are examples. And mannitol, used to reduce intracranial pressure, can cause a specific type called osmotic nephrosis.
Those not just medications, right? Other toxins.
Definitely. Think about naturally occurring toxins. Certain mushrooms, like Amanita species, animal venom, snakes, spiders, scorpions, can cause AKI through various mechanisms like rhabdomyolysis or hemolysis, even excessive intake of certain foods like rhubarb leading to oxalate overload, and environmental toxins. Ethylene glycol, antifreeze, causes severe AKI with oxalate crystal deposition. Heavy metals lead, mercury, cadmium, arsenic can cause tubular damage. Inhaled solvents.
What about drugs of abuse?
Yes, they can cause kidney damage too. Cocaine can cause AKI through vasoconstriction or rhabdomyolysis. Heroin has been linked to certain types of glomerulonephritis. Ecstasy can cause rhabdo or hyponatremia, anabolic steroids.
The takeaway is nephrotoxin exposure is serious.
Very serious. It increases morbidity, mortality, hospital stays, healthcare costs, and importantly, increases the risk of developing or progressing to chronic kidney disease later on. So, awareness, avoiding unnecessary exposure, especially NSAIDs, monitoring renal function and drug levels when appropriate, and managing AKI promptly are all critical.
Okay, let's switch gears completely for our final segment. Assessing renal function in children. This needs a different lens, doesn't it?
It absolutely does. Kids aren't just small adults. Their physiology is different, they're growing rapidly, and assessing kidney function requires a much broader approach than just calculating a GFR. The clinical evaluation right at the bedside is paramount.
What's the first thing you look at?
Growth.
Yeah.
It's absolutely essential in pediatrics. Poor growth, short stature, poor weight gain, falling off the growth curves can be one of the earliest and most sensitive signs of underlying chronic kidney disease in a child.
Why does CKD affect growth so much?
Multiple reasons. Poor nutrition due to decreased appetite or dietary restrictions. Metabolic acidosis can inhibit growth. The mineral and bone disorder, CKD-MBD, affects bone development. There can be resistance to growth hormone. So, meticulously plotting height and weight on the appropriate centile charts is non-negotiable. Always use the same scale, measure accurately.
What else is key at the bedside?
Anemia. Just like in adults, the kidney makes EPO, so CKD leads to anemia. But also consider poor diet and chronic inflammation. You need to learn how to properly examine for pallor conjunctivae, palms, tongue, and blood pressure. Many kidney diseases cause hypertension even in young children. But interpreting BP in kids is tricky because normal values change with age, gender, and crucially, height. You must use BP centile charts or validated apps, and using the correct cuff size is critical for accuracy. Cuff bladder length should be about 80% of the arm circumference, width about 40%.
You mentioned CKD-MBD earlier. How does that manifest specifically in a growing child?
It's particularly devastating in children because it affects growing bones. Remember the pathophysiology.
Yeah.
Low active vitamin D, poor calcium absorption, high phosphate leading to secondary hyperparathyroidism. This disrupts normal bone formation and mineralization, leading to renal rickets or renal osteodystrophy.
What signs might we see?
Clinically, you might see bowing of the legs, genu varum or valgum, thickening of the wrists and ankles, a rickety rosary beating along the costochondral junctions of the ribs, bone pain, and fractures. Labs will show that typical pattern. Low normal calcium, high phosphate, very high PTH, and often high alkaline phosphatase reflecting bone turnover.
What about the general physical exam? Any specific clues for kidney problems in kids?
Definitely. Look carefully for edema, signs of fluid overload, or heart failure. Check for dysmorphic features. Certain features like low set or abnormal ears or preauricular pits are strongly associated with underlying congenital kidney anomalies. Look for skin rashes. Hannock-Schönlein purpura, HSP, causes a typical palpable purpuric rash on the legs and buttocks and can cause nephritis. Lupus can cause various rashes. Palpate the abdomen carefully. Can you feel enlarged kidneys or a distended bladder? This might suggest obstruction, like posterior urethral valves, PUV, in boys. Examine the genitalia for abnormalities. And a careful neurological and spinal exam is important, looking for signs suggestive of a neurogenic bladder.
Okay, moving to lab tests in children. What are the basics?
Similar basics to adults, but interpreted in the context of growth and development. Full blood count for anemia, but also checking white cells and platelets, important in conditions like HUS or leukemia affecting kidneys. Urea and electrolytes, UNE, to estimate GFR using pediatric-specific equations like the Schwartz formula. Check potassium, sodium bicarbonate for acidosis.
And the movie labs.
Yes, calcium phosphate, PTH, alkaline phosphatase to assess for CPD-MBD. Albumin and cholesterol are important if you suspect nephrotic syndrome.
Urine tests, still crucial.
Absolutely. Urine analysis is key. A clean catch or midstream urine, MSU, for microscopy, culture, and sensitivity, MCNS, if you suspect a UTI. A urine dipstick checking pH, looking for renal tubular acidosis, specific gravity, concentrating ability, blood, and protein.
How do you quantify protein if a 24-hour collection is impossible?
We use the spot urine protein. Creatinine ratio, UPCR, or albumin. Creatinine ratio, UACR, often on an early morning sample. It correlates well enough for clinical purposes. You might also do more specialized urine tests like fractional excretion of sodium, FeANA, to assess tubular function, or urine osmolality for concentrating ability.
What about imaging? What's the first line, usually?
Abdominal ultrasound is almost always the first imaging test. It's non-invasive, uses no radiation, and gives great information about kidney size, shape, structure, detects hydronephrosis, swelling due to blockage, cysts, tumors, stones, and can assess the bladder wall. Highly valuable.
What other imaging might be needed?
Depends on the question. A plain abdominal x-ray, KUB, can sometimes show kidney stones or large bladder stones, or assess for constipation, which can affect bladder function. Nuclear medicine scans like a MG3 scan can assess differential renal function, drainage, and look for scarring, especially after infections or an obstruction. Avoiding cystoretherogram, VCUG or MCUG, involves putting contrast into the bladder via a catheter and taking x-rays as the child voids. It's the gold standard for diagnosing vesicoreteral reflux, VUR, and posterior urethral valves, PUV. CT or MRI provide more detailed anatomy but involve radiation, CT or sedation, MRI, and are usually reserved for specific indications.
Maybe a few quick case examples to tie it together for the students.
Sure. Imagine a 10-year-old boy with painful urination, dysuria. Dipstick shows blood, but urine culture is negative. An X-ray might show a large bladder stone.
Okay.
Or a child in an endemic area like South Africa presents with blood mainly at the end of urination, terminal hematuria. Classic sign of bilharzia, schistosomiasis, affecting the bladder.
What about an infant?
A 4-month-old baby boy presents with his first UTI. On exam, you feel easily palpable kidneys and maybe a distended bladder. Ultrasound confirms hydronephrosis and a thickened bladder wall. An MCUG confirms posterior urethral valves, a congenital obstruction.
Nephrotic syndrome.
A 5-year-old boy comes in with puffy eyes, especially in the morning, maybe some leg swelling. He might have a history of allergies, entomopy. BP is normal. Urine dipstick shows 4+ protein, minimal blood. Classic presentation of nephrotic syndrome, likely minimal change disease at this age.
A nephritic.
A 10-year-old girl had a sore throat about 10 days ago. Now she presents with high blood pressure, noticeable swelling, maybe shortness of breath, and her mom says her urine looks like Coca-Cola. UN microscopy shows dysmorphic red cells and red cell casts. Classic acute nephritic syndrome, highly suggestive of post-streptococcal glomerulonephritis.
Those examples really help visualize how these conditions present. Okay, well, we have certainly taken a deep dive today. We've covered the core physiology, CKD diagnosis and complications, specific pathologies like diabetic and hypertensive nephropathy, the dangers of nephrotoxins, and the unique aspects of pediatric renal assessment.
Yeah, quite a journey through the kidney. The key takeaway for you as you prepare for exams in the wards is that understanding the kidney's functional anatomy, how the glomerulus and tubules work, is absolutely central to understanding why different diseases present the way they do.
That link between structure, function, and clinical presentation.
Exactly. Is it a podocyte problem causing leaky protein, nephrotic? Is it inflammation messing up filtration and causing hematuria, nephritic? Is it vascular damage from diabetes or hypertension? Is it a tubular toxin? Your ability to connect the clinical picture, the labs, the imaging back to that underlying pathophysiology will be your most powerful tool.
And a final thought to leave you with. As you continue your studies, really think about the kidney's incredible ability to compensate. It can maintain function for a long time, even when significant damage has occurred. While that's protective short-term, it means disease can progress silently.
Which makes early detection, risk factor management, and intervention even more critical.
So what further questions does this deep dive spark for you about preventing kidney disease or improving long-term care for these patients? Something to keep thinking about. Thanks for joining us on the deep dive.